Yeah, I think that's a great question. So I think that a one size fits all approach doesn't work because patients aren't all the same. They're very different. They have different ages, they have different comorbidities, they have different infections that require different antibiotics. And so I think what works better is having a personalized approach, especially if we have antibiotics that are less toxic. I don't think it makes sense to monitor them the exact same way as antibiotics that are more toxic. And I think that we can also look at patients' social factors and their comorbidities as well. And we can tailor monitoring to those specific factors. Sure. So in terms of clinical factors, I think that we need to look at the patient's comorbidities. So we can look at their renal function, look at their liver function. We can also look at the type of infection that they have. And the duration matters as well. So some patients may be on a shorter course of therapy, other patients might require a longer course of therapy. I think we can look at the drug itself. So again, drugs like cefazolin, ceftriaxone, there's been a couple recent OPAT studies that show the percentage of abnormal labs when we get weekly labs is very, very low. One particular study mentioned a 1.3% of rate of abnormal labs. And so I think if it's lower toxicity, we can monitor that less often and still be safe. Another big thing is to make sure we provide our contact information to the patient so they can contact us if they're having any adverse effects as well. So I think the drug itself matters, and then social factors. If we have somebody, sometimes patients, they don't have great transportation, or I practice in a very rural area, so it's not easy for patients to come to the lab and get labs every week. Sometimes they're working, and I've had numerous patients tell me that they can't get to the lab every week because they're working during that time and they can't just leave their job. So I think we have to think about a lot of the social factors as well and individualize patient care based on those. So I started the OPAT program in 2017, so I've had almost 9 years of experience now. And I think when you first start an OPAT program, it makes sense to have a similar approach for all patients getting weekly labs because you're still learning, you're still developing your program. And at that time, OPAT in the US was a newer concept. Programs were adopting this concept, but I think now 9 years later, we've had a lot of time to learn about how OPAT works. And I think that one of the big lessons that I've learned is that we need to put the patient at the center of care, because sometimes I think there's things that sound good on paper, like doing weekly labs on everybody. Sometimes it makes us feel better, it makes us feel like we're being more careful, but it doesn't necessarily improve outcomes in every situation. I think there's a lot of studies that show that there's a lot of time consumed in terms of tracking down labs, and with these low toxicity antimicrobials, it's not necessarily very toxic, so we don't always have those big abnormal labs. And then just figuring out patient social issues as well. Every patient is different, and so they might have a different job, they might be homebound, they might be healthy and going to school, and so I think just doing what is safe, but also tailoring it to what is convenient for the patient and what works in their lifestyle. And so I think that the biggest lesson for me is to make sure that the patient is at the center and that we're doing what's safe, but we're doing what works for them as well.